Well, good morning, everyone. Thank you for joining our seminar today. I know for many, the concept and talk of COVID is something that's wearying, and people are ready to say, let's move on. But I think it's important for us to reflect on experience as COVID-19 has pushed our local public health units across the country nearly to the breaking point. During the COVID experience, from my position here in the Department of Public Health at NDSU, I've been a participant in community events, radio interviews, letters to the editor. I've done research and data analysis for our state. I've also supported my own and other churches to know how to respond to COVID. So those are some of the experiences I've had over the last 2+ years during COVID. But the one thing I have done that I think is of real significance is to actually listen to the local public health professionals who were working on the front lines and who were most impacted by public reaction to COVID. So since March of 2020, local public health professionals have been challenged with heavy workloads, taking on new responsibilities, and at times enduring misunderstandings from the public because of their responsibilities to carry out their government mandated roles. Now, this presentation will report on the results of a local public health reflection activity that a group of us held in June of 2022 at the Dakota Conference on Rural and Public Health. So today, I hope when we're finished with this, that many of you as attenders would be prepared to conduct a debrief or reflection activity with a group of public health professionals who have shared a common and challenging experience. I also hope that you'll have a good understanding of where we have been in North Dakota through COVID-19, and then also that you'll have best practices for how to move forward in the event of potentially a future pandemic of this nature. So by way of background, Gestalt theory is Gestalt, you're probably familiar, is a German word that simply means an organized whole that is perceived as more than the sum of its parts. And Gestalt theory is based on the concept that helping people process a series of individual conflicts and making sense of those in a whole, in a contiguous way, is beneficial. You know, we in the upper Great Plains are stoic, hardworking, and long-suffering. In fact, we probably take pride in the concept that whatever doesn't kill you makes you stronger. So after a difficult experience, just be thankful you didn't die and move on to the next task. But this is a problem emotionally and interpersonally, as people need to build solidarity through shared understanding after a difficult experience. It's also a problem professionally because we sacrifice valuable lessons that could have been learned through reflection. The North Dakota public health workforce is in need of support on many, but I would argue 2 levels. One is guided reflection on what they have experienced. And second, capturing best practices as a way of reminding ourselves of what we have accomplished during COVID and empowering us, by capturing best practices and giving us confidence that we can do even better in the future. I'd like you to pause for a moment and reflect on your own COVID experience. I've seen the survey data, so please do complete that short 4-question survey, but I'd like you to just reflect for a moment. What role have you played during COVID? And what have you contributed and what have you accomplished in that role in service to your community? What are you particularly proud of? And on the other hand, what do you wish you could do over again? How has your experience gone? And what have you lost? And what have you gained during this time? Those are some thoughts that we asked the participants in our reflection session. And today I'm going to share with you some of what they said. But before we do that, I want to remind us of where we have been. You know, memory is a funny thing, and it's amazing how in just 2 short years, it's easy to forget a lot of what has happened. And so I would like to take a short time at the beginning to do an epidemiological review. Now, if you're coming today hoping for a super detailed epidemiological report on what's happened, you will be disappointed, because today's purpose is to listen to our frontline persons. But I do think it's important to set the stage with some epidemiological reviews. So March 13th of 2020, the national emergency was declared by our president. North Dakota on May 15th of that same year, just 2 months later, launched what was called the North Dakota Smart Restart Program, basically saying we're now through the emergency. Now we can get back to some semblance of normalcy. But if you look at what the 2 years since the Smart Restart started until now, you could see that at the time we started the restart, the challenge had only just begun. Our most difficult time was in the fall of 2020, when we saw many cases and deaths. Our mask mandate was put in place on March 13th of 2020. And as you can see, it was in the middle of the peak of new cases, which also matches the peak of mortality. Vaccine was made available in early January of 2021, and you can see the impact that had on cases. And then you can see when Omicron emerged in January of 2021, we saw this resurgence. This is the journey that we have been on. Another way of looking at it is cumulative deaths. And so you can see when the Smart Restart program started, as I said, we had only just begun. The mask mandate in our state went in place, and it lasted from November 13th, 2020 to February roughly of 2021. So it was less than 3 months in duration. And then you'll see that the mortality was just, kicking in at that time that the mask mandate went into place. Now, let's just remember for a moment, the deaths on this chart represent individuals, our grandparents, friends, people we know. I'm sure everyone in this call knows someone who succumbed to COVID. Now, this epidemic was not avoidable, but it could have been more successfully mitigated in order to lessen the impact. But I also want to make clear that we all acknowledge, we in North Dakota, in the United States, and in the world, we're paving the road we were walking on. So I want to be careful to consider the circumstances under which leaders were making decisions. We don't want to further compromise our solidarity as a public health community, as a state, by retrospectively accusing or blaming, and thus worsen our ability to face the future in a unified way. However, we want to critically evaluate our experience and our purpose in order to explain and prepare for the future. So here is how the pandemic unfolded in our state. So the left side shows the North Dakota Smart Restart metric. And this is basically showing that every county in North Dakota, using our state metric, which was based on active cases per 10,000, testing rate per 10,000, and the proportion of tests positive. And that was the criteria. And through September 3rd of 2020, our state was still being reported as being all in low risk in the green category. And yet you can see here on September 3rd, we were already starting into a significant uptick in cases. At the same time, the map on the right is what the Harvard metric, which was essentially built primarily on incidence, new cases per day at any given time, which is the classic method of measuring an epidemiological outbreak. And you can see at the same time, middle July, the Harvard metric had our state as largely in high risk at that same time. We can see the development across the country. It started in the coast in August. North Dakota had a few communities that were in the red area of high transmission and high incidence rates. By September 4th, it was increasing. By October 9th, most of our state was in deep red with 500 per 100,000 new cases per day. And then by November, we were over 750 cases, new cases per day in most counties. And so this is how it then spread through the state. Here's another way of looking at the incidence rate just for our state. You'll see there where the mask mandate was put in place was when the incidence was increasing significantly. And you'll notice that we had the highest incidence rate in the country. Now, those other gray lines are all the other states. Blue is South Dakota, who had a similar challenge to ours. But you can see that we were the highest for 98 straight days. And then mortality, similarly, the red line represents North Dakota's mortality rate over time through January of 2021, and then South Dakota in blue and all the other states in gray. And you can see, if you notice, early on, we were very low, and all those gray lines early on were higher. And I think we were deceived into thinking that because we're rural and have less population density, that we would be spared. And in fact, that turned out not to be the case. Now, mind you, during this time when we were the highest rate in the country, people were picketing school boards and refusing to allow mask mandates. And a lot of challenging things were happening at the very time when we most desperately needed to stand together in the face of a serious outbreak. Now, why was it that we ended up with such a high case rate and mortality rate? Well, one reason is we had very low mask use. This purple line is North Dakota, the blue line is Minnesota. And you can see we had nearly the lowest mask use rate through most of the summer of 2020, when the epidemic was really taking off here in North Dakota. Another reason was low social distancing. So this, the percentage is the percentage of change in mobility or activity in your life. And you can see from North Dakota, the purple line, we had limited change in our mobility. In fact, we were, almost the same, almost no change for most of the time. So we were reluctant to limit our mobility. And then finally, vaccine coverage. You can see here that, those white counties in southwestern North Dakota, Grant, Billings, and Slope County, less than 40% vaccine coverage. On the other hand, some of the eastern state counties, such as our tribal communities, are all over 70%, Rowlett, Ramsey, and Sioux counties being examples, plus Sargent, Ransom, Cass, Grand Forks, Nelson, and Cavalier counties having higher than 70% vaccination coverage. So variable coverage, but low coverage in much of the state also contributed to the growth. Now, what was the result of this at local public health? Nationwide, the pandemic resulted in several consequences for public health work. 82% of local health departments reassigned staff to support pandemic response activities, but had nobody to replace them. That resulted in chronic disease prevention service delivery being reduced by 76%, substance use prevention activities by 65%, maternal and child health activities by 60%, and then other infectious disease work such as Hep C and HIV screening was also compromised during that time. And if you look at the right, that chart there, you'll see that obviously, the teal color to the right is the level of increase. So emergency preparedness and epidemiology and environmental health inspections, immunizations, those all increased during the pandemic. But then the blue bars going to the left shows the degree of reduction. So the majority of those common public health services, tobacco, maternal child health, blood pressure screening, et cetera, were all compromised from anywhere from 39 to 75%. Additionally, those public health workers who were being transitioned into work that they weren't really prepared for in COVID work, leaving behind the work that they were meant to be doing. But then in the face of that, they were misunderstood by many in their communities. Nationwide, 61% of public health professionals reported harassment during COVID-19. And harassment means social media or internet protesting their orders or sanctions. It also meant directed attacks at individuals through social media, as well as direct attacks to an individual or a family's safety. 70% of locally governed public health departments reported experiences of harassment, whereas 31% of state governed local health departments reported harassment. So what that shows is the more that a local health department was locally governed, the more likely the local persons were to turn on that public health department. And this is a nationwide study. This isn't North Dakota, but that's quite disconcerting. So what that shows is that the constituents respect the state level mandates or guidelines, But if it's local, they don't trust their own local leaders. And so you ended up with more than twice as much harassment to the degree that it was a locally administered health department. And I've shown here most of the common types of harassment I've already shown here. There were also coordinated demonstrations against public health in public settings. So this is, so in the winter of 2021 and 22, I had this burden for our local public health administrators across the state. I had written multiple letters to the editors of newspapers across the state, defending public health and defending our local public health professionals. And in fact, at the end of the slides, I have a list of those letters if you're interested in reading them later. But during that time, I had this desire to provide more support to them. So a team of persons made up of colleague Rick Jansen, Adam Homan, and student Savita Singh, as well as Dr. Stephen McDonough from Bismarck, set out to create an activity to host at the Dakota Conference. And that's what I'm primarily wanting to present today. And I want to acknowledge, I considered when I was struggling with in the face of these challenges, I wanted to serve them in some way. And I wanted to hear from them and allow them to speak out from their own perspective.
Good morning. Okay, have you got that booster shot?
Yep.
Okay, can a guy get one or can't he?
You
Is there any?
I have to look and see when we have it.
Okay, I've got it muted. Oops, I muted you too, Dr. Strand. Just a moment.
Okay, does that help?
Yes.
Okay, so what did we actually do? Okay, so we conducted a 2-hour intensive session for public health professionals and others from across North Dakota at this conference in June 2022 up in Grand Forks. There were 48 individuals broken into 9 groups comprised of 4 to 7 persons per group. Each table chose a facilitator and a recorder. The session began with a 20-minute presentation of our experience, similar to what I just presented to you a few minutes ago. And then each table had a list of guiding questions with time for the recorder to record responses. This is the list of guiding questions. So things such as, what factors enabled your response? What factors impeded your response? How did local public health collaborate with local medical systems, nursing homes, et cetera? How did you perceive the communication coordination? What role did your local emergency operations plan play? And what were some of the successes you had? And then the challenges were, what risk mitigation efforts did you implement and how was it communicated? In the absence of higher level mitigation measures, how did you protect your citizens and what could you have done? What were the challenges you faced and how did you overcome them? What mistakes did you observe and how might we do better next time? And then how can we use this experience to strengthen public health moving forward? So these were the questions that were asked of them. And then finally, they did a short poll on their experience. So we used the thematic analysis of McGuire and Delahunt, where the research team independently analyzed the results, from which we then generated key themes. And today I'd like to introduce the 5 key themes that resulted from our work. The participants were from these professional affiliations. So 22 out of the 48 are public health, frontline public health persons, a fair number of university, others from healthcare, some citizens, health insurance, and then those are the participants. And this is what the event looked like up in Grand Forks. And here's what the groups looked like around the room, each of them working for an hour and 20 minutes on the questions that they were assigned. So what were the results of this listening session? 5 key themes emerged from our experience: communication, leadership and collaboration, data management, community relationships, and resources and planning. And I'd like to pause and share some of what the attendees said about each of the key themes. So first, communication. In a crisis, communication is critical. This involves communication from experts to authorities and authorities to the people, and from leaders to those whom they are called to lead. Our Governor Burgum did a great job of getting out on his daily press conferences, communicating empathy and compassion toward our state and toward our individual citizens, and seeking to resonate, and it seemed to resonate with the people. The state, swiftly enacted targeted urgent public health measures such as school closures, high contact business closures, travel limitations, limitations on gatherings, and a moratorium on residential evictions for tenants impacted by COVID-19. However, as I showed in an earlier slide, this only lasted for a little more than a month. And so that was the communication approach here across the state. And some of the comments made by the participants in our session are shown below. Someone said messaging communication issues nationally, locally was confusing and not consistent. There was an over-exaggeration of positivity information being used to benefit the individual or entity using the data, and felt honest communication was lacking among state officials. And in quotes, of course, are the actual words of the participants. Public health experts needed to know how to improve communication about difficult and complicated subjects, and how to provide scientific information and keep it meaningful for the general public. So I think this was a little bit of an acknowledgement that we in public health ourselves did not necessarily do as well as we could have at communicating about difficult subjects and providing scientific information in a timely manner. So in the face of this, we were challenged by things such as groups like the Midwest Public Health Coalition emerged and came on the scene. They were supported by national sources of information that were largely misinformed, fighting any government interventions. And so those individuals and those groups were providing confusing messages, which made it difficult for local public health to stand up to that because there was such an appetite in the public for some of that misinformation. So next time, along the lines of communication, we will want to get out in front of the communication challenge and not be afraid that it's hard to communicate, and then because of that, to avoid communicating, but rather to get out in front of it. Also and this is a quote from a participant, to begin with the initial conversations and proactive education, such as infection control and disease process. So I think, again, because people were inclined to jump right into the most controversial or difficult aspects, such as a mask mandate or get your vaccines. And the recommendation from that individual was, in public health, we should have started by just more general conversations to increase people's general awareness about infectious disease and about epidemiology as a way of increasing our shared and common language. Another recommendation is to convene community stakeholder meetings to discuss intended mitigation measures so they could convey it to their constituents. So instead of just handing it down through public communication channels, to actually sit down with groups. And this happened in counties quite a bit, actually. Some of the groups talked about how that was happening. So, but it probably could have been done better. And then public health experts need to serve as content experts to government leaders. And that was, the government leaders were also under tremendous pressure to make decisions. And I believe that relying on their public health experts could have also been stronger. And so a lot of the communication messages focus more on personal conveniences, such as ability to move and travel and keeping businesses open and not interfering with school sports activities and such, as opposed to focusing on actual epidemiological evidence and risk. Okay, so that's communication, the concerns that our participants reported, and then also some best practices that we should be aware of for next time. The second key theme was leadership and collaboration. Government, public health, healthcare, business, and community leaders need to collaborate for the good of the public and provide leadership appropriate to the level of their authority. And boy, this was a challenge. Every leader at any level, whether it was a school board president or a school principal, whether it was a pastor or a business leader or a city commissioner, or county commissioner, or a mayor. It was a real challenge. So there's a lot of feedback from the participants about this topic. And the model of leadership that was used at the state level was to communicate the perceived level of risk to the public and then convey to the people of North Dakota that they were free to make their decisions about how to respond, assuming that they would be doing what was in the best interests of their neighbor. Many people did, no question. But it appears from the way the epidemic played out that it wasn't enough as to really truly mitigate the spread of the epidemic in our state. There was also a strong message that conveyed confidence that individuals would act in the best interests of their neighbor and take that responsibility. And this was some of the reasons why we had a delayed mask mandate, rather short-term mitigation measures for businesses, schools, and churches, and then ultimately low vaccination coverage, because it was primarily assumed that individuals would do the right thing. From the participants at this event, in this activity, the majority found this approach, although from a good place, that is trusting people to do the best and do the right thing. In their experience, they found it to be insufficiently supportive of them in their work, leaving them to lead on their own, and they believe contributed to worsening the situation in the state. So that in September of 2020, school boards were left to fight things out in person, in public, and in ways that were not healthy. In fact, Fargo, there was a group of persons who tried to recall school board member Tracy Newman, who is our local epidemiologist, because of her support of a mask mandate. So those were opportunities where higher level leadership was needed in order to support lower level leaders below them. So some of the lessons that came out of this conversation were that local health departments, this is a positive lesson, collaborated with community physicians, hospitals, nursing homes, pharmacies, schools, universities. So there were a lot of local health leaders who said they collaborated very nicely with other health-related persons in their communities. So that's fantastic. Local health departments also collaborated with each other by frequent conference calls and a physician advisory group to advise them about how to respond and what to communicate. But the burden of decision-making was placed primarily on communities during the height of the pandemic. In fact, one of the individuals pointed out that it's clear that hospital leaders and physicians have a lot of credibility in our communities, but for some reason during COVID, they were maybe too busy or maybe not wanting to get involved in the controversy, that sometimes individuals from the hospital or medical system who could have had more influence chose, and this is the quote from the participants, not to have an open and honest discussion with the public about the severity of the pandemic and support for the measures. Now, many hospital leaders and physicians did, but the perception of these participants was that they wished it had been more. And in fact, a negative example along those lines was that some healthcare workers, such as certified nurse assistants in long-term care facilities, one of the groups reported, were not abiding by COVID mitigation measures, and they stuck together, bringing risk to their patients. And then finally, a priority on testing and contact tracing was placed over masking and social distancing. So these were some of the experiences reported. And so for next time, for other viral epidemics that emerge that are highly transmissible, warning components need to extend beyond the states, beyond local communities. Government and state leaders should collaborate across borders to communicate risk and promote solutions together. These efforts must be prompted and supported by the federal government, which has the capacity to extend additional resources when necessary. So that issue of the role of higher level leadership and its relationship to resource allocation will be brought up in the last section that we look at here at the end. And so in many ways in the state, our leadership model was reflecting what's called subsidiarity. This is a strong value in North Dakota. And frankly, one can understand a pioneer state like ours, you need to have individuals able to solve their own problems at the local level. But in a pandemic, the need for higher level leadership is significant. So the notion of pushing decisions down to the lowest level put a lot of responsibility on individuals who perhaps didn't have the expertise to even understand the epidemiology very well. But then also they may not have had the credibility, the authority, the gravitas in those communities so that their word would carry weight. And we saw that by more than twice as many communities where the local health department was a locally run health department had accidents, had evidences of reported harassment. And so I think this is a lesson learned and an important one, that we need support from the higher levels. Okay. Theme 3, data management. A pandemic is a scientific public health challenge. Viruses have no political affiliation. So evidence-based guidelines using real data are necessary to inform decisions. But I acknowledge and I have empathy for any leader during the COVID pandemic because the evidence is being generated in real time about a disease we know very little about. Back to my prior comment, we were paving the road that we were walking on. So let's not be too critical or too hard on individuals who were struggling to do the right thing. But one area where we could have done better is more up-to-date data management systems and more utilization of the existing data to inform decisions. So here are some of the lessons that came out of, and by the way, the theme data management really is the whole process of data collection. So from public health professionals, hospitals, government officials. It also includes data sharing between community members and health officials, and also information, presented to the public about that. And so in this section, we'll look at how to use that data. So again, back to the tables. So what they talked about was data management includes, respondents complained of no data, lack of data, poor data, and lack of technology in public systems, start using paper forms and faxes. Lack of transparency at the state level with the severity of the situation. And again, these are quotes from participants. Quote, at state level, we were not following data, remediations were wrongly implemented, and state leaders minimized the severity of the situation. It has been said. Two respondents' impressions were that the wrong data values were presented. So this called it a deceptive metric, that is the number of people recovered, not necessarily useful. And then only death seemed to be the only bad indicator. And then this person said, well, what about hospitalizations, number of days out of work, missing events, etc. And one person said presented data in clear and easy to understand ways. So I felt like there was a lot of data made available to us here in North Dakota, but a lot of people were not necessarily able to know how to interpret or act upon that data. And so that's where we perhaps could have used that data better. I would like to point out that a paper was published in the American Journal of Public Health last month that reported that as of June of 2021, and it evaluated COVID reporting to the CDC by all states. It reported that North Dakota only submitted 5% and 20% of case numbers and mortality numbers to the CDC, placing us at 8th and 14th from the bottom, respectively, in that regard. So in the future, we want to use validated metrics for risk assessment that are based more in science. And then we want to share data early and then guide local public health and communications strategies. And then finally, we need to strengthen local public health data analytics capacity. And this is both a technology issue, more automated systems, as well as skills of those local public health professionals who will be inputting the data, analyzing and using that data. So the third main theme was data management. The fourth theme is community relationships. We know that actions happen at the local level, and community relationships can make or break a response in a crisis. We found in North Dakota, many communities reported that prior relationships had allowed them to quickly pivot to collaborate across their community because of that strong community solidarity. The participants reported that all healthcare related organizations participated in response, and most participants reported that these relationships were strong and supportive. So the relationships with other healthcare professionals were largely positive. I'd like to point out that one participant mentioned that tribal workers were quick to respond, and there was a great working relationship, referring to working collaboratively between tribal and non-tribal agencies in the county. So that's good. And we know that tribal communities were disproportionately affected, more cases, more mortality. And yet individuals did report those communities were collaborating nicely. So it's sad that the consequences were still so high. And then regarding community relationships, it was mentioned that there is so much loss. This is a participant's comment: loss of clients, loss of friends and family, and loss of a career. By November 16th of 2020, nearly 24% of North Dakotans knew someone who had died of COVID, and nearly half knew someone who had been infected with COVID. Loss of loved ones was devastating, and loss of professional recognition was also mentioned by participants in this session, including comments such as, "Now we have concerns about the public wanting to take away public health authority and reduce the impact of public health activities and laws." Some communities experienced big challenges as school boards, churches, business leaders, city leaders were struggling to make decisions on their own. So when trust was high and a prior relationship was strong, it was able to endure and became a resource for COVID response. But where trust was not high and solidarity was weak, then the fractures and fissures intensified. In December of 2020, Renee Mock, administrator of Bismarck-Burley Public Health, reported being harassed and threatened. She was accused of being a tyrant and a Nazi for performing her duties as the coordinator of the local COVID-19 task force. So let's just remember, infectious disease epidemics are community problems. Certainly, it's individuals who contract disease and suffer, but response to the epidemic needs to be a community-wide response. And I'm not sure that we implemented community engagement principles. We in public health did not implement community engagement principles to the extent that we could have. Now, I'm not justifying the bad behavior of individuals in communities who contributed to divisiveness or hostility, but I am trying to own, from our perspective in the public health community, that we could have also done more. Community relationships are defined as the relationships that an organization has with the people under whom who operate underneath them. And participants in this study really focused on the importance of those relationships. And some of those comments that they made, I've already alluded to here. So next time, with regard to relationships, one individual said community trust was at the heart of the rural community response. So that was a positive. And then another said strong ties to community partners to prior relationships and familiarity was very beneficial to our community. So those were some good things to report, but there was also loss as well. So concluding the community relationships section, this final quote: "It is extremely important to create strong collaborative relationships with community organizations in advance because you will need to rely on those relationships in your response." So that's the work we can do now. Let's strengthen our community solidarity. Let's strengthen community engagement principles in public health work. And the last comment I have here is that the Public Health Code of Ethics contains 9 elements on the topic of community relationships. So I'd like to invite us all to refresh our familiarity with the Public Health Code of Ethics to learn from the experience. The final key theme is resources and planning. So public health emergency response, taxes and challenges, space, staff, and supplies. So here's where we needed federal support or state level support. And we got that. Many of the state agencies were the ones supporting local public health. But in a crisis like this, states, especially lower population states like ours, do not have the resources to respond alone. And we needed the support of the federal government in this case. 55% of nursing homes reported staff shortages. Nursing homes reported building and ventilation was inadequate. Building configurations mitigated against COVID. Difficulty moving residents to a COVID wing without exposing them to others was a problem. Older buildings had no room for isolation. So these were some, resource challenges that were felt. Some of the comments, we were doing the best that we could with what we had. There was a point that local emergency operations plans, quote, were exercised over the years with many plans in place, yet those were ignored at the state level. And second, I quote, no emergency operations plan has been developed that even came close for this scope of the pandemic. So there was some concerns that a lot of the emergency operations planning that had been done resulted in what is called the paper plan syndrome, which is an illusion of emergency or disaster preparedness due to the belief that it can be accomplished by the completion of a written plan. A final comment was that procurement of supplies such as personal protective equipment was a challenge. And here we used the state supply of PPE. So the state certainly was involved in providing those resources. Another commented, we ordered PPE from wherever available, even at increased costs. So resources and planning was a challenge up and down the leadership hierarchy. So next time, we should be doing after action reports, and lessons learned are the best tools to move forward. And that's what we're trying to do here today. And also a comment was made that we need to update policies and procedures. So these are the 5 key themes that came out of this listening session. And some of the lessons learned in summary from the listening sessions were that public health needs to respond quicker and in a more unified manner. Many of you are familiar with North Dakota native Mary Wakefield, who has now been tapped from CDC Director Rochelle Walensky to reorganize the CDC. So certainly public health from the CDC on down to our local levels are doing our own reflection in trying to improve performance, acknowledging areas where we could have done better. The state health officer needs to represent the state government as a reliable voice, representing the science of public health and the policy authority that is required of them by the state government. Long-term care facilities represent vulnerable populations, and these national treasures need to be protected. Tribal communities were hit very hard, and close collaboration between state, local, and tribal communities was reported to be quite good, but this always needs to be considered as paramount. And I should remind you that vaccination coverage in North Dakota was highest in our 3 counties that are primarily tribal community counties. So they took that very seriously and were leaders in our state in vaccine uptake. Evidence-based risk assessment tools are essential to communicate true risk to the community. No one wants to have to be the one to step up and enforce measures, but I would suggest that governmental, civic, and health system leaders need to use the authority in the service of the common good. And even if it means some kickback or negative response, that's our responsibility when we assume leadership. Misinformation should be publicly corrected by the appropriate persons. News media committed to scientific integrity are essential, and our local media tried to provide that support. I mentioned already, community engagement needs to be stronger, so more use of community coalitions and more and earlier communication to them. Public health at the community level needs to be strengthened with increased funding, staffing, and informatics capacity. And I also think we saw in our state, smaller county health districts collaborated with their regional networks across the state. So that was also a good sign. Now, after the listening session, the participants completed a short survey, and I found this very interesting. So if you look at the green represents strongly agree. And so if you look at the third line, I was able to share best practices from the pandemic today. So I was pleased that these 48 persons universally considered that to be one of their main benefits, was they were able to share their best practices. The second highest was I learned about North Dakota's experience with the pandemic. So we all lived through it, but we didn't necessarily evaluate it as we went along. And so they found it helpful to be reminded what had happened. The third was that I was helped to process my emotional experiences. So again, we were pleased that that was accomplished. And then the last one, balancing life and work, was deleterious to my well-being. That was just more during COVID. And you can see the majority said that it was. The first line, in spite of some of the negatives, you'll see that there was strong agreement that I have strengthened my resolve to devote myself to public health, and only 2% disagreed with that. So these were some of the this was some of the feedback from the participants, and we were pleased to see that. Now, I would like to, before I move on to my conclusions, I would like to pause, and I'd like to open it up for questions and invite you to share any lessons you would like to share from your COVID experience. So you can either, maybe Ramona can handle the chat if you want to post a question in the chat. And we can have a time of conversation, and then I have a few minutes at the end to draw some final conclusions.
I am happy to monitor the chat, and feel free to unmute yourself and share any of your reflections with Dr. Strand.
Renee, which journal article are you referring to? I'll follow up with her later. Any questions on this? So today I've tried to represent our local public health professionals. I've tried to allow them to speak into the situation and learn from them. Question, is there a pandemic preparedness committee at the North Dakota state level? Adam Holman, what did you learn in your practicum last summer about that?
So what I do know is there is a pandemic plan, which looking at that's run through the North Dakota Department of Health Emergency Preparedness and Response Division. That plan was pretty spot on for, basically everything we've seen through COVID. I don't know if there's a specific committee per se, but I know that there is certainly a pandemic plan through the North Dakota Department of Health, which, like I said, from seeing that through the internship, very spot on. I think you hit some really big points. I think the biggest difficulties in COVID overall was just the patchwork of how each community chose to mitigate and or respond. And I think you kind of were spot on when you talked about that earlier. So that's about all I can probably say as far as if there's a committee or not.
Thank you, Adam.
Mark, was there any feedback from any of the participants that touched on the state health officer and how the instability in terms of having 3 appointed during that period and so forth?
Yeah, that was mentioned, that there was little sense that there was representation at the state level of public health by way of the state health officer, and then also limited support at the local level from that position in terms of the decision-making kinds of positions. But I would invite anyone who's on this call who works in local public health to respond to that. How did it play out to see a lot of instability with our state health officer during COVID?
While people are thinking about that, Dr. Strand, Paula asks, what factors do you think led the tribal communities to be willing to participate in the vaccination efforts compared to non-tribal communities?
I see a couple of persons on this call who are closely connected to our tribal communities, and I'd like to invite them, if any of them have anything to answer to why our tribal communities were more supportive and more receptive to the vaccine. Does anyone have anything to offer us who's working in tribal communities? the main thing that I think of is just more solidarity. They perceive themselves as one community. And so if we as a community have need of taking some action, then we do that together. But I don't know if anyone on the call can help us with that question. I don't want to call anybody out and put them on the spot.
Hi, Dr. Strand. I can talk a little bit about that.
Thank you.
Hi, everybody. My name
Tell
is
people who
Liana.
you are, Liana, please tell them who you are, and then we welcome your input.
Sure. Good morning, everybody. My name is Liana, and I'm an MPH student at NDSU. I am from Tucson, Arizona, and I'm a member of the Navajo Nation. So I think part of it is what you said, Dr. Strand, was just the solidarity. But also it's cultural. I think a lot of it was cultural. The way the messages were put out from our tribal leaders, specifically our president, and other members of the community, about how important this is. And it was aimed, not only just about yourself, but you think about your household, you think about the next generations, and your neighbors. And the protection is not, it's not just about you. You can't be selfish. So I think that was a big part of it. And then the availability also. So really credit our public health, our IHS facilities on Navajo for making it really accessible and easy. That was a big thing. So going from chapter to chapter, community to community, holding these vaccine clinics from 8 a.m. to 8 p.m. every day in a different community, because we have a lot of barriers of transportation. There's only 5 clinics on Navajo and 5 major clinics on Navajo, and we're the biggest nation in the country. So, things like that. So I think there was a lot of little factors that just happened to make a huge difference.
Liana, thank you. I recall your involvement too, 2 years, in May of 2020 at that time. So thank you for sharing that. Did anyone else who has experience within our tribal communities want to share anything about that experience? Oh, there's Jacob. Jacob, would you mind sharing it verbally? Thank you for the chat, but would you be willing to share that? So you can
Hi,
see.
it's Shelly.
Oh, yes. Go ahead, Shelley.
Jacob is a little busy right now, so I'll just add a little bit more to what he typed into the chat there.
Shelley, can you tell the listeners, who you are and where you are, and then go ahead and share your thoughts. Thank you.
Okay. So my name is Shelly Davis. I work for the Foundation for a Healthy North Dakota. It's actually a new foundation that just started this year. We actually just recently took over as the state's immunization coalition. And so what Jacob is speaking to there, I think it was mentioned actually too with what she had stated, but in terms of, yes, like what he spoke to, infrastructure of IHS, inherent trust, good, bad. I think in terms of the history with the lack of trust in government, you wouldn't have anticipated that the American Indian population would have had the coverage rates that they did. And it's something that I think of as a success story, specifically here for North Dakota. Obviously with some of the federal policies, attempted genocide, things that were as recent as, the 60s, 70s with the sterilization of Native women, being considered research in the area of IHS. And so I actually think it's quite a success story in the fact that we had the highest coverage rates out of any other racial group for that initial series of the vaccination. What Jacob speaks to here with the greater good, our children are sacred. We needed to protect our elders, our wisdom keepers, our language speakers. And so I think that's what Jacob was trying to speak to there with his comment. And like I said, just reiterating everything she had stated earlier too, I completely agree with all that, but that's just my take on it.
Shelley, thank you. Are there other questions or comments regarding how we responded, lessons learned, mistakes made, even experiences that anyone would like to either ask about or share with the audience?
Dr. Strand, this is Ramona.
Mhm.
What could we be doing actively right now to be rebuilding that relationship and trust in public health?
That's a really good question. It's something that I think a lot about, and certainly we're seeing, papers now in the American Journal of Public Health and other places coming out. I think the first thing is we need to reflect on our experience and do, after action work. What did we learn, and actually do formal after action reports, and then share those reports with the public. That's our obligation as government, public health. I think that's certainly one piece of it, but I think equally so, rebuilding community, coalitions. So local public health units beginning to have, say, occasional events for the community where they just sit down in a public space and invite individuals to come and either ask questions or even a more formal structure, such as local public health being the one who convenes these coalitions to bring them together. They have done this, frequently regarding specific issues such as opioid risks or obesity or tobacco coalitions. So bringing together coalitions is certainly one of the greatest strengths of local public health. But I'm not sure that we have done as well doing that for the purpose of bringing together shared understanding of our community's goals and aspirations. It's typically focused on sort of solving one specific problem. So better use of the data to do after action reports and more listening with our community stakeholders and community organizations and leaders to rebuild that trust. Anybody else have any suggestions for what we can do to rebuild? So to me, it's the two-part question. First, we have to rebuild the trust by improving in areas that we indeed were not trustworthy. And I think mixed messaging is one of those, some of the issues. But then also, I think we need to rebuild trust in areas where we were trustworthy, but we were unfairly maligned by some as not trustworthy. There, I think we just need to have reflection times and open conversations. So to me, it's both improving in areas where we didn't do as well as we could have, as well as advocating for ourselves and not allowing ourselves to just sort of be bullied in some ways by public messaging, which is not necessarily designed to be constructive, but is, in some ways maybe more destructive.
I have a follow-up to that, and I guess as your colleague, I'm wondering, have you changed at all how you're teaching our current public health students regarding how we want them to be prepared to handle this when they are out in the workforce?
Not as much as I probably should be. But in epidemiology, we've definitely done reflection on the COVID journey and had conversations like we're having now. But yeah, definitely, I think we need to help our students to learn from this, and so that when they move out into public health leadership positions, they will be asking more of the data. They will be investing more in building community coalitions, using the principles of community engagement, and that our students will continue to strengthen that. And our local public health leaders have been doing a great job, no question about it, but nobody was ready for what we had to face. And so the fact that it revealed areas that we could improve on, well, that's just to be understood. That's no criticism of any individual.
as people who may need to pop off here at the 11 o'clock hour, we actually have another half hour dedicated for you to have your concluding comments and also more questions. I'm just going to pop in the chat a brief note about what we're going to be doing in our October session, October 14th, and I invite people to come hear about the research that some of our current students and alumni will be presenting at the upcoming American Public Health Association conference.
Okay, well, I'll go ahead and move on to some summary thoughts then. First, let me show you the results of the survey that we took at the beginning. So during the COVID pandemic, my main roles have been, so that in order were direct response, evaluator or researcher. Number 3 was a healthcare provider. Number 4 was I didn't have a specific role, more of a community member. And then other, I'll have to see what those were. So those are the participants. And then my main work is academic or research is first, state or local public health is second, student is third. And then has my workplace had any formal post-COVID reflection or after action activity? The majority said no, but I would welcome it. And then some have said yes for reflection and after action learning. That's good to see. And then, another one, yes, for only action after action learning. So it has been happening. So that's good to see. And then the last, I would describe the attitude toward COVID in my workplace as COVID is still here and we need to remain vigilant. That's the first. People understand what to do, so there's no need to do anything special. That was second. Third was it's under control, so now is the time to evaluate. That's third. Fourth was we're done with it, drop it, let's move on. So I guess I'm not surprised with this audience that was a lower response. So let me have some concluding remarks here. So public health credibility has been challenged by COVID mishaps, and public health authority has been compromised by new legislation. In the italics is the good news to parallel with maybe the first line, which is more sobering news. However, public health has emerged in the national conscience as a legitimate and important entity. Second, public health funding was shown to be inadequate to respond to a crisis, but the American Rescue Plan Act provided $350 billion in emergency public health funding. And in June 2022, the CDC announced $4 billion over 5 years to improve public health infrastructure, workforce, and data systems. And I imagine that Mary Wakefield's reorganization of the CDC will include additional avenues for funding. The third point of bad news maybe is that public health capacity was severely challenged by COVID-19. But the good news, in the next 5 years, we will have the opportunity to rebuild and transform public health. And I'd like to ask our attenders, what public health future will we create? So in review, I hope I've been able to demonstrate that a group debrief or reflection activity with a group of public health professionals who have shared a common and challenging experience is both feasible and helpful. And I hope some of you will choose to maybe consider what we had done in your own sphere of influence to potentially help your own coworkers as well. Second, reviewing the North Dakota COVID experience from an objective and somewhat removed posture allows for new learning. And then finally, taking lessons learned from real experience by listening to frontline persons is of value in preparing for a future response. Now, what can I do? First, I'd like you to consider digging back into history and reading an article by Lewis Harris called Benefits to be Derived from the Epidemic, published in the American Journal of Public Health in 1919, upon the heels of the 1918 influenza pandemic. And you'll see copies of it right there. And it's very interesting and it feels very similar to today. And I'd also like you to, from the modern perspective, to consider reading articles from the March 2021 issue of the American Journal of Public Health, shown over there on the right side, which also had some really good articles and reflection on our experience. So read some good materials to learn from our past and current experience. And then I'd like you to, write your own response to the question, what are the benefits to be derived from the COVID-19 pandemic? And you might do that by writing, or you might do that by conversation. And then do whatever public health role you do conscientiously and with effort to try and continue to rebuild and transform public health in the next 5 years. Here are some letters to the editor that I wrote, which if you're interested in seeing, you could have access to those. In fact, I'll pop those into the chat to make it easier for you to get them if you want them. Maybe it just gives you an example of how to do that. I'll do that in a minute. Let me finish by acknowledging my coworkers who helped me on this project: Ali Welsh, Rick Jansen, Dr. McDonough, Savita Saidu, and then Adam Holman. So thank you to this team who spent a lot of time over the last couple of years working on this project.